As my topic suggests, I'll be talking about big data, and I'll also be talking about innovation in cardio-oncology. These are my disclosures. So I'll be asking what is big data. I'll be asking how it's relevant to cardio-oncology. What resources do we have to interrogate these questions? What's happening in this space? And what are the emerging technologies in cardiology and oncology? And are they being used optimally in cardio-oncology? So when we think about big data, this is some of the words and the themes that come up. We think about volume, we think about storage, we think about capacity, we think about processing. So when it comes to the cardio-oncology space, or to really any domain, it's a way of looking at big data sets to answer some common questions. Registries and electronic health records are probably two of the main sources in terms of the big data. And the question often arises, why can't we answer everything with a randomized controlled trial? And the reason is that, the big data sets are retrospective and they can offer real world evidence. So there is definitely a role for big data outside of RCTs. And of course, depending upon the results of a big data analysis, it may lead to a prospective trial in the future. So let me give you some examples, a couple of examples of big data in cardio-oncology. So the SEER Medicaid database, this is a US-based database, and it links two large population cohorts, both from the oncology side and also from the non-oncology side. The SEER is the Surveillance, Epidemiology and End Results Program in Cancer, so a wide, large database in the US looking at cancer patients, and Medicaid is one of the governmental US insurance programs. So this is a study that was done by Avi Guho, Daniel Addison, and colleagues, where they looked at atrial fibrillation in breast cancer patients, and this is in a big data set combining those two. So the reason, why are we looking at big data? Because we need to have a question which hasn't been answered. So this was the question, AF in cancer patients. We didn't really know too much about this. And they used the SEERS database. So this is the cancer database. They used a 2007 to 2014 period, and they identified females above 66 with breast cancer. They then matched them one-to-one with the Medicare database, and the Medicare database here, these are non-cancer patients. Altogether, they had nearly 85,000 breast cancer patients, and 11% of these had a pre-existing diagnosis of atrial fibrillation. Now, new onset atrial fibrillation was diagnosed in 3.9% of the patients who developed breast cancer. Interestingly, in the non-cancer patients, the diagnosis of new atrial fibrillation was 1.8%, so half of that of cancer patients. So apart from the traditional demographic and other risk factors, the stage of breast cancer was an independent risk factor for the development of atrial fibrillation. So not just breast cancer, but the stage of breast cancer was a risk factor. And it was also found that new onset atrial fibrillation in these breast cancer patients was associated with increased one-year cardiovascular mortality. So very important results here. So this is another database that I will now concentrate on. This is the FAERS database. This is from the FDA, the Food and Drug Administration database in America. And this is a database that records all adverse effects in patients taking medications in the US. And as an example, in 2017, they received nearly 2 million reports. And at the moment, there are nearly 20 million reports in this database, the FAERS database. So what did we do in this database? So this was a study that I was involved with, looking at the side effects of CAR T therapy. So for those who are unaware, CAR T therapy, or chimeric antigen T cell receptor therapy, is a new therapy for a lot of hematological cancers, and also now being used in solid tumors, and also outside of cancer and HIV as well. And at the time, we wrote this a few years ago, I think 2020 maybe, and at that time there was limited data on cardiovascular toxicity in these patients. So what we found was that 20% of the patients receiving CAR-T therapy did have cardiovascular toxicity. The mortality was high, so nearly a third of the patients with cardiovascular toxicity died. We also found that arrhythmias were common and that there was an association between neurotoxicity and cardiotoxicity, the so-called ICANS. This is a dendritic hierarchical model of the cardiovascular toxicities. So you have the cardiovascular toxicities in the red down below, and apologies if we can't see them, but on the side we are seeing the clustering of a variety of non-cardiac toxicities, mainly the neurotoxicity. And of course, we should not forget the electronic health records. These are large sources of data, EPIC, Cerner as examples. This is a study by Vlad Zaha's group in Texas, and they looked at their electronic health record system in their own institution. Now, what is the advantage of using an electronic healthcare record? You can get real-time data. So they enrolled all the patients in their cardio-oncology clinic. They were able to determine how many of the patients were low risk, medium risk, high risk, and they could follow these patients in real time and determine what were the toxicities and how best to intervene, how many patients were started on medication, how many patients were not started on medication. So this is an example of using big data in a very real-time accessible format. Registries, of course, this is another source of big data. This is a collaboration that I'm involved with, led by Diego Sadler from Cleveland Clinic in Florida, and this is the Global Cardio-Oncology Registry. Now, what is the aim of this registry? Again, the same as any big data, the aim is to answer common questions. And I was talking to Dr. Zainab earlier today about how I will be managing a patient differently, she will be managing a patient differently, somebody else in another country will be managing things differently. It's because different countries will manage patients not exactly in the same way. However, the questions that we have, we need answers to are the same everywhere. What is the cardiac risk? How best can I decrease the risk? How can I improve the cardiac outcomes and the cancer outcomes? And the way to answer such questions is by doing international collaborative approaches such as the GCOR registry, again showing the role of big data. So coming on to emerging technologies, this is the COIN project that led by Sherry Ann Brown in America that I and many others are involved with. And what is the COIN approach? Innovation. We need to go for machine learning, digital technology, telemedicine. All of these approaches together will allow the appropriate role for education, the appropriate role for advocacy, and this is the way that we can try and change the way in which cardio-oncology education and care is delivered. Machine learning. This is a Hong Kong group that is quite active in this space. And they did a very interesting thing. They looked at imaging and cardio-oncology. They looked at deep learning. They looked at artificial neural networks, and they created a random forest model to try and understand, is there a way that machine learning can improve outcomes? And what they found was, using this kind of MDT machine learning approach, that yes, they could identify these patients earlier, and maybe this was something that could be used in clinical practice. And we, of course, the last thing I would mention is precision. We cannot forget about precision. If you look on the top left, you have traditional data. This is very heterogeneous, very mixed up, patient records, patient charts. You then try and go for stage 2, which is deep phenotyping. You look at the electronic health records, you try and get a bit more granular information, and then ultimately you apply AI, you apply machine learning to get to the precision medicine stage. And of course, this is the aim for all of us when we see the patients. We have the guidelines, we have the documents, but really what we want to know is, the patient sitting in front of me in clinic, what is the best treatment for that individual patient? And that is, of course, precision medicine. And this is how, going from traditional data, deep phenotyping, we will get to SAGE. My time is up. Thank you very much.